Hello everyone, and welcome to our Advanced Cardiovascular Life Support (ACLS) training session. Today we're going to focus on the management of stable and unstable tachycardia, following the American Heart Association (AHA) 2020 treatment guidelines. My name is AJ, and I'm an ACLS instructor with over 20 years of experience. We'll cover a detailed description of the medications used as well as the primary and secondary assessment of the patient. Additionally, I'll provide information about One-Call CPR, which offers AHA BLS, ACLS, and PALS courses in Dallas, Texas. You can find more information or schedule a course at www.onecallcpr.com. Let's get started. Tachycardia is defined as a heart rate greater than 100 beats per minute. It can be classified into stable and unstable forms based on the patient's hemodynamic stability. Stable tachycardia. The patient has a rapid heart rate but maintains adequate blood pressure and perfusion. Unstable tachycardia. The patient exhibits signs of poor perfusion, such as hypotension, altered mental status, signs of shock, ischemic chest discomfort, or acute heart failure. Now, let's move on to the primary assessment. When you encounter a patient with suspected tachycardia, your primary assessment is crucial. This involves the following steps. 1. Scene safety. Ensure the scene is safe for you and your team. Use personal protective equipment, PPE, as necessary. 2. Assess responsiveness. Check if the patient is responsive by tapping and shouting. Look for any signs of life. 3. Activate emergency response system. Call for help or instruct someone else to activate the emergency response system and get an AED, automated external defibrillator, if available. 4. Airway, breathing, and circulation, ABCs. Assess and maintain the airway. Provide oxygen if the patient is hypoxemic. Monitor the patient's breathing and circulation. 5. Check for pulse and rhythm. Evaluate the heart rate and rhythm by checking the pulse and attaching the patient to a cardiac monitor. 6. Identify and treat underlying cause. Obtain a focused history and perform a physical examination. Look for potential causes such as hypoxia, hypovolemia, electrolyte imbalances, or toxic exposures. Once the primary assessment is complete and initial interventions are in place, move on to the secondary assessment, which includes a more detailed evaluation and specific treatment plans. 1. 12-lead ECG. Obtain a 12-lead ECG to identify the type of tachycardia. Determine whether the rhythm is narrow complex or wide complex tachycardia. 2. Stable versus unstable tachycardia. Assess whether the patient is stable or unstable. Look for signs of instability such as hypotension, altered mental status, ischemic chest discomfort, or signs of shock. Now let's discuss the management of stable tachycardia. In cases of narrow complex tachycardia, often referred to as SVT, the initial step involves instructing the patient to perform vagal maneuvers. These include the Valsalva maneuver or carotid sinus massage, but only if no carotid brutes are present. If these maneuvers prove ineffective, the administration of adenosine is the next line of action. Start with an initial dose of 6 mg rapid IV push, followed by a saline flush. Should the first dose not achieve the desired effect, a second dose of 12 mg may be administered. For wide complex tachycardia, treatment options include anti-arrhythmic medications. Amiodarone can be given at 150 mg intravenous over 10 minutes, followed by a continuous infusion of 1 mg per minute for the first 6 hours. Alternatively, procainamide may be administered at a rate of 20 to 50 mg per minute, intravenous until the arrhythmia is suppressed, hypotension ensues, or the maximum dose of 17 mg per kilogram is reached. Another option is sotalol, administered at 100 mg or 1.5 mg per kilogram over 5 minutes. In cases of regular narrow complex tachycardia such as atrial flutter, rate control can be achieved using beta blockers or calcium channel blockers, for example, metoprolol or diltiazem. Lastly, for atrial fibrillation with rapid ventricular response or RVR, management includes rate control with beta blockers or calcium channel blockers. Additionally, consider anticoagulation if atrial fibrillation persists. Immediate synchronized cardioversion. First, prepare for cardioversion. Ensure the patient is on a cardiac monitor. Obtain intravenous access and provide sedation if the patient is conscious and time allows. Now let's discuss synchronized cardioversion doses. For narrow regular tachycardias, start with 50 to 100 joules. If it's narrow irregular, consider 120 to 200 joules biphasic or 200 joules monophasic. For wide regular, use 100 joules. Wide irregular should be treated with a defibrillation dose, and remember, this is not synchronized. After cardioversion, reassess the patient's rhythm and vital signs. Provide antiarrhythmic medications as needed to prevent the recurrence of tachycardia. Now let's delve into a detailed description of medications, starting with adenosine, which is used to treat stable narrow complex tachycardia that does not respond to vagal maneuvers. The initial dose should be 6 mg rapid intravenous push, followed by a second dose of 12 mg if the first dose is ineffective. Follow each dose with a saline flush. Moving on to amiodarone, an antiarrhythmic medication used for both stable and unstable wide complex tachycardia. For stable tachycardia, administer 150 mg intravenously over 10 minutes, followed by a continuous infusion. For unstable tachycardia, administer during or after cardioversion to maintain rhythm. Next, procainamide, used for stable wide complex tachycardia, particularly if the rhythm is of unknown origin. Administer 20 to 50 mg per minute intravenously until arrhythmia suppression, hypotension, or a maximum dose of 17 mg per kilogram is reached. Sotalol is another option for stable wide complex tachycardia. Administer 100 mg, which is about 1.5 mg per kilogram, over 5 minutes. Lastly, beta blockers and calcium channel blockers are used for rate control in atrial fibrillation or flutter with rapid ventricular response. For metoprolol, administer 2.5 to 5 mg intravenously over 2 minutes. You may repeat every 5 minutes up to a total of 15 mg. For diltiazem, administer 0.25 mg per kilogram intravenously over 2 minutes. You may repeat with 0.35 mg per kilogram after 15 minutes if needed. One-call CPR. If you're looking to further your training in BLS, ACLS, or PALS, One-Call CPR offers comprehensive courses in Dallas, Texas. Their experienced instructors provide hands-on training to help you gain the skills and confidence you need to handle cardiovascular emergencies effectively. For more information or to schedule a course, log on to www.onecallacpr.com. In conclusion, managing stable and unstable tachycardia requires a systematic approach based on the AHA 2020 guidelines. It involves a thorough primary and secondary assessment, appropriate use of medications, and timely intervention with synchronized cardioversion for unstable cases. Always remember to identify and treat underlying causes, as these can significantly impact patient outcomes. Thank you for watching. I hope this video has provided you with a clear understanding of the management of tachycardia. Stay tuned for more in-depth videos on other aspects of ACLS. Don't forget to like, subscribe, and hit the notification bell to stay updated on our latest content. Stay safe and keep learning. See you in the next video.